You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is February 16th, 2024. We will be doing a patient management case over CVID presented by Dr. Thao Lee. She is an allergy and immunology fellow at Children's Mercy Hospital. Go ahead and get started on my patient management conference. So there's a little bit of interaction, so if you guys can help participate a little bit, that'd be great. So for this patient, this is a 20-year-old female who presented to your allergy immunology clinic as a referral from her primary care physician for evaluation of recurrent infections. She says that she's doing okay, but endorses that she frequently feels fatigue and productive cough. She feels like she is never well and is tired of feeling like she always frequently has to see the doctor. She has frequent infections and also prolonged antibiotic courses, primarily within the past couple of years. So you'll get some more immunology history on the next slide. Prior to this, she had no past medical history. She's never had a surgery. Her family history is limited because she's adopted. In terms of social history, she's a never smoker, she's a social drinker, and she denies illicit drug use. She has no known allergies, and her vaccines are up to date, including flu and COVID. For her immunology history, so for her upper respiratory infections, she feels like she has a cold that includes fever, congestion, and cough at least once every 3 to 4 months. Sinus infections, she's had 3 to 4 sinus infections every year for the past couple of years, and it does require treatment with antibiotics. Ear infections, she hasn't had any in her adult life, but recalls having ear tubes as a child. For pneumonia, she's had 2 or 3 in the past couple of years, with the most recent episode about 6 months ago. Bacteremia sepsis, 1 6 months ago that required hospitalization, but she can't remember what bacteria. She has not had a meningitis before, bone or joint infections, skin infections, thrush, fungal infections, or warts. She has had the flu or COVID, but she's not sure. She just thinks she did because she hasn't gotten tested before, but feels like she probably did. Eye infections, none, and urine infections, none. Joint swelling and redness, mouth sores, easy bruising, and recurrent fevers and diarrhea are all negative. For antibiotic courses, she's had them about 3 to 4 times this past year. She recently just received another course of Augmentin for a sinus infection about a month ago. Hospitalization-wise, she's had 1 to 2 per year because of acute hypoxic respiratory failure secondary to pneumonia. The last one was, as mentioned before, was 6 months ago, where she was actually in the ICU because of the bacteremia, and she needed mechanical ventilation, that should say pressors, and IV antibiotics. For her ED and urgent care visits, she says she has too many to count. At this time, what are your differentials?
Saw a lot of pneumonias on there with bacterial infection, so you're always worried about more of like a B cell type of issue, so like a hypogan, like a CVID, type of picture. So yeah, so just all like the kind of the B cell, kind of stuff. E cell kind of related stuff wasn't kind of sticking out to me. I think I've learned recently you always have to think about other things that it's not even allergy, so chronic cough, fatigue, even like something like parcoid or something else like that. But I know we're having an allergy lecture, but just some other kind of things. That I was also kind of thinking about, but like a CVID or like a specific antibody like deficiency, due to kind of the big ones that was kind of sticking out to me, like especially like with our age and stuff too.
Yeah, CVID I don't know why my brain went to that first, but I'm guessing it's maybe something else.
All right, so that's a good way to go through it. So for differential, sorry, go ahead, Dr. Miller.
Yeah. I was going to throw in CF is a possibility in ciliary dyskinesia.
Yep. So those are great too. I didn't include those on my long list of differentials, but complement disorders you can think about too based off the different types of infections that they have. But I think SOSA did a really good job, and I think that's why I love the immunology dot phrase so much, because it helps you kind of think about which part of the immune system may be more of the issue and kind of help guide your differentials based off the type of infections they're having. So with all the pneumonias, the sinus infections, you're thinking more of like B-cell related or humoral immunity that may be affected. If you're starting to see a lot of like weird, wonky, kind of like fungal or viral infections, then you start to also consider more of those cell-mediated disorders. And so I think that's really helpful. And I have another slide too that I use to kind of go through patients sometimes and their syndromic disorders to help me kind of better understand some of the clinical presentations they may have. So we talked about complement disorders, but when we think about hypogammaglobulinemia, I think it's also important to kind of assess primary and secondary causes of this. So whenever we're on call and stuff, you're going to get different types of pages from different services. And so they're going to kind of ask you, is this essentially, there's a low IgG that came back, you know, would they benefit from replacement therapy? But then you have to ask yourself, well, is this a primary disorder? Is this a secondary disorder that in order for this to actually improve, do you need to correct the underlying issue, right? So for something that's primary, you're going to think of your inborn errors of immunity that may result in a similar presentation in addition to other clinical symptoms that may be present. Secondary causes, you think of things that can either cause decreased production or increased losses. And so I know Sosa and Dr. Miller had one that they had to go through recently and was able to find kind of like a secondary cause of a immunoglobulin loss. But when you think about examples of decreased production, you want to remember about drugs. So example like this would be chemotherapy agents like rituximab. You know, I think there's been times where we may have gotten calls, or, you know, our hemonc friends are probably familiar with this as well, where they'll check kind of their immunoglobulins after chemotherapy and notice that they're lower, so they may be on IVIG as replacement therapy. But you want to think about other medications that can cause low IgG too, especially when a patient's been hospitalized for a long time. Think about your anti-epileptic agents such as like carbamazepine, phenytoin, and valproate. If you think about a lot of your other adverse drug reactions and things like that, I feel like anti-epileptics is just there and it causes a lot of different issues like DRESS syndrome and hypogam being one of them. Long-term steroid use can also cause decreased production. So if you can kind of recall too, with patients who are on long courses or long tapers of prednisone over time, one of the side effects is that they have a suppressed immune system. So those patients also sometimes are also on like prophylactic antibiotics, but this is another byproduct that can happen as a result of it. Other conditions that can result in secondary hypogam would be like malignancy. So this is also more kind of like for some of these conditions in older patients. So when you think about like CLL, that's kind of like an older adult patient that may present with that. Lymphoma, which can present in like this age of a patient as well or older. Multiple myeloma, again, you can see this more primarily in adult patients, but again, something to think about in terms of a low IgG. And then Waldenstrom's macroglobulinemia. These patients have somewhat to a degree of similar, like a B-cell disorder, but they also will usually have like ocular symptoms as well. And then there's also thymomas with hypogammaglobulinemia, which is also called Goodpasture syndrome. Some examples of increased losses. So you think about patients who have protein-losing enteropathies. So this includes patients with like intestinal lymphangiectasia or like nephrotic syndrome, which I feel like I've seen kind of more of these nephrotic syndrome type patients with increased losses. So this is like a little document that I think Dr. Raju sent out to us like a year, but I've just kind of had it on file. But it's kind of the different phenotypic classifications for human inborn errors of immunity. And I really like it because they kind of separate different disorders. Obviously, there's probably more than what's listed there, but they have it in a nice little table based off the type of like deficiencies that you're suspecting or what type of which part of the immune system that you think could be affected. And then this kind of, when I go through it for some of them, there's this and then another one where it'll talk about like the phenotypic kind of presentations of those patients, meaning like, do they have facial anomalies? What other parts of the like multi-system things that may be involved? Like, do they have enteropathy? Do they have like diabetes? All that stuff that also will be included in this chart. So sometimes what I'll do is kind of go through the document and like think about what symptoms my patient has and say, oh, they have this, like could it be potentially this disorder? Does it match with the history that I'm getting? And so when I kind of looked at these, you kind of think about what disorders could they possibly be, and I think this is helpful for kind of identifying what labs you may want to get initially. And then for some patients too, depending on what they're coming in with, whether it's just low IgA, do they have low IgM, etc., you'll kind of be able to find out like even specific or selective, like isolated immunoglobulin disorders as well. So I use this quite a bit whenever I'm in immunology clinic. So based off what you know so far, what initial labs would you guys get?
So probably starting with like the basic things that we do, like CBC with DIP, flow cytometry, all the immunoglobulins like A, G, M, and E, complement, titers to vaccines, like tetanus, diphtheria.
Any other thoughts, Sosa?
Yeah, I mean, you just went through like secondary reasons, and even with some patients, Dr. M, so you can consider getting like a UA to see if there's any like kind of protein loss or anything like that. You can, and if we're work, like just like like just in general, if we're thinking about a protein losing like like a protein losing enteropathy, you can get a what is that thing that you get in the stool called? Oh yeah, like a is it an antitrypsin level like in the stool or whatever?
Yeah.
But I think for this patient, yeah, but I think that's it. But for this patient specifically, I mean, I think it will just be, I mean, operation would be like more bangs from a buck would be the CBC with diff complement, um, um, immunoglobulin levels, and your vaccine titers would probably be a good starting point, plus or minus a flow for me.
Yeah. So for the labs for this patient, so we did get a number of different things. So we did get a CBC with a diff and then a flow TBNK, which were both normal. We also did a B cell naive and memory panel, which showed decreased class switch B cells, but it was otherwise normal for the naive and memory counts. Immunoglobulins showed undetectable IgG and IgA, and there was also low IgM. In terms of the rest of the studies, the LPM, the CH50, CMP, SPEP, UPEP, peripheral smear, were all normal. And then they had pneumococcal titers, which were absent, and diphtheria titers were absent. And this patient, I may have forgotten to put it on the slide, but they are fully vaccinated as well. Or actually, I did have that. So I think you're right, Sosa. I have seen us get kind of like an alpha-1 antitrypsin before, especially in some patients, if they have like GI symptoms that are present, like chronic diarrhea or something that makes you think they're having a loss through that form. I feel like for SPEP and UPEP, we don't always get, but this is again to kind of help screen for that multiple myeloma type picture. And again, there are some things too that some people will do based off of like a CMP. If you have like a protein gap of greater than 4, then you start to ask yourself like, well, where is that other protein kind of present? So you just take the total protein minus the albumin, and if that's greater than 4, at least in residency, that's what we would kind of go off of. And, other signs of multiple myeloma are also going to be like renal dysfunction, hypercalcemia, and things like that. So again, you can kind of look at the whole patient as a whole and kind of use that to guide some of the differentials, but I don't always see that we get the SPEP and UPEP as well. Let's see. So based off of these labs here, what would be your next step in evaluating this patient?
Well, I mean, obviously, we have in low immunoglobulin, so we have a low IgA and an IgA, so we're really worried about more of a hypogam, like type of situation, but also with our pneumococcal titers, like could it be also like a CVID picture with the low IgA, and like in the so pretty much we have 2 low immunoglobulins plus low pneumococcal titers, so obviously like you'd give the pneumovax booster, and then you'd see what would happen about 4 to 6 weeks later to kind of see next steps. That'd be what I would kind of do. It's kind of my thoughts.
Yeah, exactly. And so something that came up yesterday in clinic with Dr. Raja and I is you can be very suspicious of CVID, and we'll talk a little bit more too about that. But there's different levels that you can use, but typically when you're kind of assessing for the diagnosis, especially with kind of this day and age with insurance and things like that, that second part of the test is going to be evaluating with pneumococcal titers to see how they're, or after the pneumovax and getting repeat titers afterwards to see how they respond. So that would be what you do. and then you get the lab 6 weeks later. The immunoglobulins are still undetectable, and then you have pneumococcal titers that are still absent, so they did not respond to the vaccine. So, again, reiterating the next one, what is the most likely diagnosis?
CVID.
Yeah, okay, awesome. So with CVID, the estimated incidence is actually 1 in 25,000 in the general population. So it's actually very common, hence part of the name. In addition to other things that you'll think about like selective IgA deficiency, it is up there with one of the things that we'll see. Most patients are diagnosed between the ages of 20 to 40 years of age, but you will also see that some of these patients may present a little bit earlier, like 16 to 18 too. I've seen some of those over at our clinic at Children's. These patients will usually present with recurrent sinopulmonary infections, and they're usually caused by organisms like Strep pneumoniae, Haemophilus influenzae, or Mycoplasma. These patients don't oftentimes have frequent viral or fungal infections. Some of the more severe infections they have may include things like, the bacteremia with subsequent empyemas as well, and then they also can have osteomyelitis and I believe even meningitis. So just some other considerations outside of the sinopulmonary tract. For CVID, it's kind of one of those things that can be, to a degree, like a diagnosis of exclusion, because there's other causes of hypogammaglobulinemia too that should be considered and evaluated, which is why you still get a lot of that other kind of workup that's done, because it's kind of just a mix of everything, and there's different sets of criteria that you can use. And I believe when I was looking at it, there were kind of 3 different recommendations for diagnosis and criteria, with some being more sensitive than others, which is what I kind of included in this presentation. And with CVID specifically, it's not always associated with a gene defect. So the cause for it is really kind of like unknown, but there are some associated mutations, which I've listed here, which is within the inducible co-stimulatory molecule, B-cell activating factor, and this TNFR SF13B as an example. Something to think about too, if you look back on this prior slide here, not all patients, so you do use the B-cell naive and memory panel to kind of help assess that function, but there are plenty of patients who have CVID that have completely normal B-cell counts and class-switching B-cells and all that stuff. So this is not necessarily a criteria for diagnosis, but can be seen in I think 10 to 13% of patients. But again, just kind of helps you with your suspicion, but does not have to be required for the diagnosis of it. So for diagnosis of CVID, I think one of the kind of quick things that we remember is that it's usually diagnosed after the age of 4, because when they're less than 4, again, depending on the clinical picture, some patients may have transient hypogammaglobulinemia. So one of the criteria is that it's after the age of 4, they will have a low IgG, and they'll have either low IgM or IgA. So there are going to be some patients that you'll find that have low IgG and completely normal IgM, but then also have low IgA. The second part of this criteria is that they also have poor response to vaccines. So whenever you're getting a patient, you're kind of wanting to ask yourself, have they already received immunoglobulin replacement therapy? Did they get vaccine titers beforehand? Because if they just got IVIG, it may be harder to assess kind of their immunity based off of those vaccine titers, since they've already gotten some form of replacement therapy. But that is a portion of what they use to help diagnose it. And sometimes I think on a couple different occasions had to try to submit stuff for a patient's vaccine titers in order to get insurance to approve immunoglobulin, which is kind of silly, especially if they've been on it for a while, but just something to consider. This table I thought was super helpful because it kind of summarizes the different criteria that's present and some of the different clinical symptoms that may be there. So you kind of have it broken down to groups A, B, C, and D. But when you look at the meeting criteria, so when they're in categories A, B, C, or ABD, it indicates that they probably have CVID, and then those patients should be considered for immunoglobulin replacement therapy. When you look at the vaccines, you also want to look at the type of the vaccine that you have. So your protein vaccines are your tetanus or diphtheria, and your polysaccharide ones are the Pneumovax. So that's also just an important concept, I think, moving forward, as a lot of kind of clinical offices are shifting to the Prevnar 20 and things like that. So when you're kind of assessing them, that's what you'll be looking for. And then I have a slide just kind of talking about the management of CVID. So one of the mainstays of treatment for CVID is replacement of the antibody, which can be done intravenously or subcutaneously. So this is your immunoglobulin replacement therapy. And typically this is dosed at about 400 to 600 mg per kilo body weight per month. So the two different methods, as I mentioned, is subcutaneous and intravenous. So when we think about the half-life of IG, it's typically about 3 to 4 weeks. But when you're doing intravenous, it's usually, again, you're going to be dosing it every 3 to 4 weeks. And if you need to do an adjustment, you kind of get the immunoglobulin level before the dose because you're expecting that to be the trough. For subcutaneous, it's usually given weekly, but there are some instances where you'll find that they'll be given every 2 weeks. And even with subcutaneous, I didn't have like a dedicated slide on it, but I know last year we did kind of like a procedural competency for it. But there's several different product options that are available, and their concentrations are different too. So there's some products that you may be able to do like every 4 weeks, but again, that's a lot of volume that they kind of infuse into their abdomen. So there's different risks that are associated with that too. When we think about subcutaneous and intravenous, like replacement therapy, I think it's important to kind of still remember the common side effects that can happen, but also some of the risks. So even though if a patient needs it, they need it, but some of the more common ones is that these patients may have like some headaches. So hydration is really important for them because I think that can really help prevent the onset of headaches. And then some people will use Tylenol. Not everyone usually pre-treats with Benadryl, which you certainly don't have to. And I don't think that we routinely do that, at least on our pediatric side. Some of the more potential like serious complications and risks are like you can have anaphylaxis, so these patients should have an EpiPen as well. You know, someone may ask you, well, if they have anaphylaxis to the medication, like should they still get it? I mean, if they need the medication, they need it, so you're probably likely to continue the infusion and try to potentially even modify the infusion rate that you're doing, especially if it's intravenous. Other risks that kind of happen too is that there's renal. It can affect your kidneys as well. And I think that risk is higher with intravenous, and a lot of these complications, I believe, are higher with IV forms. But again, you kind of still want to think about it for both of them. You can also get aseptic meningitis, and it may also increase your risk of potentially having like a clot. Again, things to consider when you discuss these with patients, but if they need the medication, then they need it. For your target of your immunoglobulin level, so I've always wondered about this because this range can be pretty variable for some people, and it kind of said between 600 to 900, and I think what's important is that you kind of reassess the patient, which we do every 4 or 6 months depending on how sick they are, and you kind of ask yourself, well, how are they doing? What was their baseline immunoglobulin before? If you have a patient who is getting sick all the time and their IG is only like 600 and they're still having issues, then you may have a higher target range, and so you may push for their dose to be a little bit higher, which we have a few of our patients doing right now. So that's kind of something to consider. When you reevaluate these patients, you get, your repeat CBC, you get CMP, you're kind of assessing for that renal dysfunction, and you get the repeat IgG as well to kind of see if they need a dose adjustment in addition to their clinical history. For some patients, though, I have like one at Truman that I'm familiar with where, she was on high dose IVIG, but she was still having pretty like frequent sinus infections. We ended up starting her on prophylactic antimicrobials as well, in addition to the replacement therapy, which helped reduce the frequency of her infections. And some of these options may include Bactrim or macrolides. And then for some patients, you may consider like transplant, but I have not seen that been done before primarily. For potential complications of CVID, so I think this is always a good one to kind of go through because there's a lot more variations than we think about. So we think about, these patients, they have recurrent sinopulmonary infections. When you have that, it causes a significant amount of inflammation. So these patients may also develop bronchiectasis, because if you remember with bronchiectasis, it's kind of like repeated cycling of inflammation. And so these patients may have chronic cough symptoms, but you'll want to think about potentially getting like a CT of the chest. You'll do spirometry to kind of assess how their lung function is as well. Other considerations or complications of CVID can also include autoimmunity. So they can occur in up to 25% of patients, and they can have conditions like immune thrombocytopenia purpura or autoimmune hemolytic anemia. So also something that you can see on your CBC and kind of asking them about any other symptoms that they're experiencing. For some of these patients, you may consider doing like a higher dose of immunoglobulin during that time for just a short period to kind of get them through that, but then you would kind of go back to their dose that they were on before for the kind of more treatment of the CVID like immune issue as opposed to the autoimmunity. For patients with CVID as well, they do have an increased risk of malignancy, such as lymphoma. So it is recommended to get a biopsy. For some patients outside of just neoplasm, they can also just develop lymphadenopathy. So again, it's really good to do like your full physical exam for these patients and make sure that you're not missing anything because of also the risk of malignancy. Some of the other complications that you can see with CVID is that they can develop granulomas pretty much like everywhere. They can happen primarily like in the lungs. I think that's what a lot of people think about, and they call that GL-ILD. But they can also happen in the lymph nodes and spleen, which are other common areas, but it can again be multisystemic. These granulomas are non-caseating and well-formed. For patients that have granulomatous disease, and then you can consider using immunosuppressive therapy with agents like rituximab and azathioprine, which we have some patients on. There are some patients who, again, who have granulomas and like they may have their GI tract that are affected. So if they start to have symptoms of like diarrhea, kind of like malnutrition, weight loss, then you may consider getting like a colonoscopy and seeing if there's any granulomatous changes there that may be contributing to their disease. We have one patient that has granulomas in the liver, and so she had some liver dysfunction as well. So again, just other things to consider as you're kind of looking at your routine labs. What other symptoms do they have? Is their CVID progressing to where you actually need to start them on another form of therapy? And that's all I have. And these are the references I used.